So I'm recording on my end, so no worry about that. All right, Bailey and Alexis are together, no problem. All right, so some questions we had up here on the board. First of which, for dosing meds, do you round to whole numbers for administration of a drug? That depends. If you're talking about liquids, it's perfectly reasonable to, dose down to the 10th of an ml, I think. For most people, they'll have access to things like dosing syringes and whatnot, so that's perfectly reasonable to do, like to a 10th of an ml. If you get down to the hundredths, that would be pretty difficult to do. We only do that for like our neonates, like in the hospital or something, if we're being that exact about it. So, but if you do down to the 10th or the whole number, it's probably fine as long as everything's within about 10% of the calculated dose there. All right. Someone said for the RX assignment number 3, do you want us to write it as a combo drug or separate or just as ramipril on its own? It's funny, a couple people were more observant than I was. For that assignment, I just switched out the ACE inhibitor to ramipril, not realizing that combo is only available in Canada. So what you could do in that case there, and I told these people this as well, is you could either pretend you're in Canada, which is, perfectly reasonable, and write it down as a combo drug, or if you wanted to write down 2 separate scripts, you could do that. And if you can fit it on the same one, that's perfectly legal as well. That's fine for non-controlled substances there, so that's fine. Let's see. So if a controlled hypertension patient has been taking a hypertension med for a long period of time, but we're not sure which dose they've been on, is it safe to start them on a low dose? Or would it be better for the patient if we started them on a high dose, considering they've been on meds for so long? That depends. You don't want to necessarily just be shooting in the dark. For this assignment, I'm just having you look up like what normal doses are. That's why I didn't want to just like give it to you in this case here. So basically what you would do is try to figure out what dose the patient was on, right? So you can ask them and they may not know. So what do you do in those situations? Well, you can always call their pharmacy. If you identify yourself as a healthcare practitioner, they're very willing to help you out. You have to have some patient identifiers like phone numbers and stuff like that, but they're more than happy to help you and get that information. That's usually the easiest way. Or family members, they have the bottles with them. That's always helpful. I always tell patients to bring their bottles with them to their visit, because that way you can actually lay eyes on it and see what's on the paper. So sometimes that's better than what their memory actually is. So, but for this one, you just come up with a dose. That's fine. But you typically want to keep it consistent. Let's see, on Unit 3, Cardiology Part 2, Slide 25, can you explain the bullet that says metabolic alkalosis contracted ECF? Yeah, that's in reference to diuretics. So basically, if you imagine diuretics mainly affecting sort of salt and water balance, right? So it's affecting salt reabsorption for the most part, so that way water follows it and you pee out that extra volume. Overall, your total extracellular fluid volume does shrink, right? So it shrinks down some bit because you're peeing out extra volume, like an extra liter or 2 a day. When you do that, all that stuff that was in the blood is still there. All the proteins and the bicarb and the glucose, everything is there. So it contracts down, and so the concentration gets higher. That's why you get a contraction alkalosis, because the bicarb relative concentration is a little higher, so it actually bumps the pH up. So maybe it's closer to like 7.4 or 5, or maybe even a little alkalotic in those cases there, so above that. So that's generally what I'm referring to in that sense. So you hear that contraction alkalosis is what that's referring to. Let's see, are DHP contraindicated in patients with CHF, or is it just contraindicated in non-DHPs due to decreased contractility? It is more so the non-DHPs, right? Because those are people who have poorly functioning ventricles in the first place, at least the left ventricle typically, and so you don't want anything to impede that any further, right? And even then, it's like hard to get like beta blockers on board because of the fact that, again, you're decreasing that contractility. We just know that with long-term mortality studies, that having a beta blocker on board for those patients does improve their outcomes. But with non-DHPs, that's not as clear-cut. There's no specific benefits that we know of with that. So in those cases there, I would stay away from the non-DHPs. But dihydropyridines are perfectly fine to add on, especially if you need like additional blood pressure control or something like that. But remember, someone with CHF, they're going to likely need to be on an ACE inhibitor anyway, at least as first line, because of the left ventricular remodeling effects that it helps to prevent. And then if you need some additional benefit, a CCB, like a amlodipine or something, would be perfectly reasonable there. Okay. All these questions popping up. It's fantastic. It's like you guys are studying for something that's only like 3 days away. No pressure, right? In what case would I prefer giving a patient a low molecular weight heparin over unfractionated heparin or fondaparinux? Great question. So that is partially up to the providers. Partially depends on what they want to do, what the protocols are for specific indications. I'll tell you, a lot of time patients will, sometimes even like specialty dependent. So for like a lot of cases, like imagine you work in ortho and you have a patient who goes and gets like a total hip replacement, right? So they're laid up in bed for a couple of days. You don't want them to develop a clot just kind of laying there with the venous blood being all kind of static. And so in a lot of cases, you don't want to necessarily have to do a lot of monitoring because you're just trying to prevent a clot from occurring. So a lot of times you'll just go with a low molecular weight heparin like enoxaparin. You can just dose it really easy. You can do like 30 milligrams twice a day or 40 one time daily, and you don't have to think about it. Patient's on it, and that's pretty much it. No more monitoring required. You could do the same thing with unfractionated heparin, but it's not as common, I would say, at least from the practices that I've seen. However, there are some places where you do want like really easily titratable anticoagulation. So we do this a lot, like in our cardiac unit, for instance. So like imagine you just had cardiac surgery, right? You just had open heart surgery, and you need to keep the patient anticoagulated, but you want to make sure they're not going to be too big of a risk for bleeding. So it's a very fine line you're treading there. And so with something like enoxaparin, you give a dose, that patient's going to be that anticoagulated for like 12 hours at the very least, right? Versus heparin having a really short half-life, I can give a continuous infusion, and based on what the APTT comes back at, I can dial in the dose either up or down a little bit, so that way I can get just right. You want that Goldilocks level of anticoagulation in that case. So that's one reason why you might use heparin over a low molecular weight heparin. Arixtra or fondaparinux, that's probably the least often used, and I'll see that more so in patients, for instance, that have maybe like a history of HIT, and they don't want to use enoxaparin because that could still trigger it off. So then you can go ahead and use a fondaparinux in that case. That one's the least common I've seen, to be honest. But I see a ton of enoxaparin, especially in cardio. I see a ton of heparin being used. So depends, right? What it always comes down to. Let's see. Why do unfractionated heparin say not absorb, but then says how to give it? Probably is referring to. So it probably has to do with the fact that it's it's a long like kind of sugar molecule, so it doesn't get absorbed orally, but we do give it subcutaneously or IV, so it can be given via that route there, which I'm assuming is what you're referring to. What can you not give to pregnant women and why? I'm sorry, is that referring to the heparins? I'm wondering. Maybe someone can clarify that one. There's stuff in there kind of all over each other. Can you explain exactly what CYP3A4 and CYP2C9 are and what happens when drugs interact with them? Boy, that's a question, right? That's a pretty broad question there. And again, we talked about it in pharmacodynamics, but I don't blame anyone for trying to repress those memories. That was a long time ago. So we have these enzyme systems that are sitting there in the liver, right? So we have all kinds of different ones responsible for metabolizing all kinds of different things, right? We have phase 1, phase 2 reactions that we talked about, with the main goal trying to get things more water soluble to prepare for renal elimination for the most part. Some things will be eliminated through the liver, but with all these different flavors of enzymes, right? So it's kind of like when you go to Cold Stone or something, it's not just like 30 flavors of vanilla. There's chocolate and there's Rocky Road and there's praline and all kinds of stuff, right? So think about CYP2C9 or CYP enzymes as different flavors of ice cream, right? They all kind of do different things. They all satisfy different sort of itches. If you got a hankering for chocolate, vanilla is not gonna cover that, right? So in that same way, certain drugs are only going to be metabolized by certain enzymes. Some of them are not super specific, and you'll see that, like for instance, like with warfarin, that can be metabolized mostly by CYP2C9, but there's also some 2C19. There's a little bit of 3A4. So sometimes it can go through multiple pathways. But the main thing we care about when it comes to drugs and interactions are whether something is a substrate, whether it's an inhibitor or an inducer of that enzyme, okay? So if something is a substrate, it just means that it gets metabolized by that enzyme. If you have a CYP3A4 substrate like simvastatin, it gets metabolized by CYP3A4, okay? So if I introduce an inhibitor on board, say something like, for instance, like a macrolide, let's say I put erythromycin on board. Erythromycin will inhibit that CYP3A4. It will make it do its job less well, and it will cause simvastatin be metabolized more slowly. So the half-life is longer, it sticks around for longer, and its levels rise, okay? So as the levels go up, it's going to be more effective at what it does, but also it can cause that toxicity. That's why we see that interaction between something like, erythromycin plus simvastatin could raise the levels up too high, leading to risk for things like rhabdomyolysis and hepatic injury, right? So in the same case with 2C9, that's just responsible for metabolizing something like warfarin. If I have an inhibitor on board for that, it's going to make warfarin be metabolized more slowly. It's going to stick around for longer, and thus it's going to be better at what it does in terms of inhibiting clotting factor formation in the liver, but it also predisposes us to more bleeding. So again, it's a fine line. That's why you monitor INR and things like that if you were to introduce a new drug that inhibits that, like, Bactrim or something like that. That's what I always think about. So if I introduce an inducer, it's going to do the opposite. So now I'm ramping up production of those enzymes. There's more of it available to metabolize that drug, so it's going to get eliminated more quickly. The half-life gets shorter in those cases, and the levels go down. And that's going to lead to less effect of that drug. So for instance, if I had someone who, say, was on something like say you have a patient with HIV, right? You have HIV and they are on a bunch of drugs that are metabolized through CYP3A4, and then they develop TB, right? You guys have covered TB already? Is that correct? Yeah. So rifampin, you probably heard about rifampin as being an antibiotic that induces CYP3A4. If they were put on something like rifampin and increased levels of CYP3A4, it'll chew through all of their HIV drugs faster, and that leads to them having lower levels of that drug. So then what happens? Well, then the virus is not going to be adequately inhibited. It's going to continue to replicate and destroy that patient's immune system. So again, you have to know the interplay here between something that's a substrate for the enzyme system, if it's something is inhibiting it, if it's inducing it, what are the downstream effects, right? Not enough just to know that this is an inhibitor. You have to know what it does if you introduce it to a substrate for that enzyme, and to know then what happens in terms of the clinical effects that you could see there. There's always kind of 2 or 3 steps down. You have to think about these interactions here. You guys are too sweet. You guys need to stop putting all these nice things about me. Honestly, I shouldn't tell my mom where these sticky boards are, because she just comes in and puts all these nice things about me. But anyway, let's see. I'm a little confused by the layout of the Part 3 cardio PowerPoint. You talked a lot about these drugs in previous lectures. However, it looks like you've added extra information into these slides. Should we focus more on the indications? You go into depth for this section. For the previous drugs, i.e. calcium channel blockers, you go into more detail for contraindications and place in therapy. No, it's all a continuation of the same thing. Here, I'm just referring to its use in something like angina more specifically, right? So kind of going a little bit more into depth on how we use it for this particular indication. So if I ask a question about angina and saying, well, what's the next best drug you should add on, or what drug would be contraindicated, you should be able to figure that out based off the answer choices that are provided there. So that's kind of how I'll do it in a lot of cases. Sometimes I'll just introduce a bunch of new drugs because it's like, you just need to know them, because when we talk about hypertension, we'll talk about those specific meds for that disease state. But then you see that there's a lot of crossover with things like ACS, there's crossover with antiarrhythmics, there's all these different situations where we'll see that come up again. So it's good to have that continuation of knowledge there. Okay. See, in the Cardio 3 PowerPoint regarding calcium channel blockers, when indicating the populations on slide 21, some were mentioned specifically for DHP, LV dysfunction, vasospastic angina. Since DHP is usually used in combination with beta blockers, would the other population be strictly referring to non-DHP, asthma, uncontrolled diabetes? Let me see. Let me go to that slide. All right, so yeah, so when it says like contraindications or intolerance to beta blockers, that's where you could use a non-DHP. So like diltiazem or verapamil are good for this case here. For the vasospastic angina, that's more of like your amlodipine. That's more of your DHPs in that case there. The asthma thing kind of goes back to the beta blockers, and the uncontrolled diabetes with beta blockers as well. So and then LV dysfunction specifically for the DHP. So you kind of have to have a feel for which ones are where you're using a non-DHP as a alternative to a beta blocker versus where you're using the DHPs as an adjunct to the beta blockers, right? And remember, never use a non-DHP and DHP together. You don't want to do verapamil plus amlodipine, because that would be too much calcium inhibition, way too much vasodilation, hypotension. You wouldn't want to do that there. Hope that makes sense. Okay, why is dabigatran an oral direct thrombin inhibitor not listed under the direct thrombin inhibitors after heparin? It is listed as an alternative to warfarin. That's a good question. So recall, that's funny, I'm like having student inception here with the room. Thank you for all being socially distant. Anyway, so point being is that when you are comparing these different drugs there, when you said like the direct thrombin inhibitors, those were like the IV medications. Those are the ones you're going to be switching patients over to if they develop like HIT or something like that. when I mention the direct oral anticoagulants, I kind of listed all those together because they kind of fit into a group of a new class of drugs that are used as an alternative to warfarin. You wouldn't necessarily use dabigatran on the inpatient side after someone developed HIT necessarily. Now that may change down the road, it may change years from now. But main point being is that, you know, if I had someone who, like, and I think about this, you know, the typical patient, like if you had like a 16-year-old who got started, a female who got started on birth control and she developed a PE, you know, is she going to want to have to go on warfarin for 3 to 6 months and have to like come and get her INR checked all the time and be disrupted from her classes and activities and stuff? No, that's kind of a pain in the rear. So instead, what you can do is you can use these new oral anticoagulants, because before warfarin's all we had. Nowadays, you can put them on something like Eliquis or dabigatran or something, and that way you don't have to do the monitoring. You just put them on a fixed dose, and they're basically good to go for that period where they need the anticoagulation, right? Versus if someone was in-house in the ICU and developed HIT, then you need to put them on an IV direct thrombin inhibitor. So that's kind of why I separated those out there. Okay. Surprise! I don't know what the surprise is, but okay. You guys are just getting silly in here, but. Okay, so I think I answered all the questions. Thank you all for the very nice things you say about that. You haven't taken the test yet, so you might have different things to say after Monday. And so, anywho. All right, that's a good review session there. Let's get started with the actual rest of the lecture here to get through some slides, see what I can finish up. So we talked about nitrates. Nitrates, the short-acting variety being really good for helping out with acute anginal symptoms, right? Because they're helping to increase nitric oxide production, and that causes inhibition of calcium influx into the cell, and that leads to relaxation of the coronary vessels. We can do that on a long-term basis too, so this is going to be better for sort of prevention of anginal symptoms in those cases. So we could do something like have like a long-acting nitrate being on, say, like 12 hours on a day and then 12 hours off. It's not used first line because it doesn't really do much to decrease oxygen demand by the heart, but it does help to kind of provide a low level of dilation of those vessels to allow for better blood flow to come through. So it uses adjunctive, typically second or third line, definitely not by itself. And so it could be useful if something like a beta blocker or calcium channel blocker is not really doing it on its own. You could add this on in some cases there. So we have a couple that are available. So for instance, we have like isosorbide mononitrate, which lasts about 12 hours a day. Lasts about 12 hours, and you're only dosing it daily. That's going to be an important point I'll mention here in just a few moments why that is. Whereas with like isosorbide dinitrate, that lasts a little bit shorter, but you're taking it multiple times a day. So the trick is with long-acting nitrates is you need to have a nitrate-free period every single day, right? So you can only use these long-acting nitrates for about 12 hours out of a day, because if you recall back to pharmacodynamics, we talked about something called tachyphylaxis, where the body, basically the drug stops being effective. Or even if you kept increasing the dose, you kept giving more and more nitroglycerin, I wouldn't see any additional benefit. The body needs time to reset itself, and so that's typically why we do 12 hours on, 12 hours off, in order to give that time to reset. And so you're like, well, what 12 hours do I keep it on? Well, when do you think you would most likely need that time? Well, probably when the patient's up and active and when the heart is requiring the most oxygen. So this is typically, you know, during the daytime if they're, you know, usually up during the daytime. But if they're like an overnight nurse or something, like they would need it at nighttime then, because that's when they're more active. Here's an example of, so these two agents here are oral, which again, that's why it lasts 12 hours, but it's only dosed daily because it gives you that 12-hour free period. Here is nitro paste. This is something where you can actually place it onto this little card here, and you actually dose it based off of length. So kind of similar to what we did with like the ocular antibiotics, ointments, and things like that. So basically you figure out how much the patient needs based on inches, and then rub that onto the paste and then slap it onto the patient's skin, and then you have transdermal nitroglycerin delivery there at that point, which is handy. You want to make sure that patients are educated when they're using this stuff to wipe it off before they apply a new dose, and they can actually rotate it around to different sites, so that way it doesn't, you know, cause, you know, maceration of the skin over time and cause some skin breakdown. So that's one thing. It's really important to make sure that healthcare providers, whoever is giving this, make sure they're wearing gloves, because you can actually find where healthcare providers can actually get side effects from the drug because they applied it without using any gloves and actually absorb some of the nitroglycerin themselves. And so you might see someone like complain about like really a pounding headache after they apply this nitroglycerin paste because they accidentally absorb some themselves. So along with that, though, you can see postural hypotension because those vessels are nice and dilated. That reflex tachycardia that we talked about before, flushing, headache is pretty commonly seen with some of these long-acting nitrates. So, as I mentioned there, you can go more into detail about things like why the tachyphylaxis occurs, as long as you know that you need to have that 12-hour on, 12-hour off because the drug is losing efficacy, you're generally pretty good to go. There's probably a lot of compensatory mechanisms, though, that kind of go into play here, most of which I don't really need to delve too much into because I got too much stuff to cover, as it turns out. But again, nitrate-free interval when patient has lowest symptom frequency, which is generally at nighttime. So who you're going to be cautious in using this with, if they have aortic valve stenosis, again, because then having that decrease in pressure may lead to some issues in terms of cardiac output, so that can lead to a disbalance and lead to some syncopal episodes and whatnot, obstructive cardiomyopathies. And this is an important one here because it's a specific drug interaction to note. Do not use these with phosphodiesterase inhibitors. And so I'm sure most of you have probably heard of sildenafil or Viagra before, right? It's that little blue pill that some older gentlemen will take in order to help them out with erectile dysfunction. You don't want to mix these drugs together, and the reason for that is, I'm not sure if I put it on there, if you recall back to the actual mechanism for the nitrates, right? If you look here, nitrates are working by increasing nitric oxide production, which increases cyclic GMP. That gets broken down by phosphodiesterase. So if I have an enzyme here that comes, or a drug that comes in and inhibits this enzyme, I'm gonna have way too much cyclic GMP. It's going to lead to way too much vasodilation. The patient's going to probably pass out or have low perfusion of the heart and can actually worsen ischemia in some cases there. So actually, the mixture of nitrates and erectile dysfunction meds are contraindicated. Okay, do not mix these two together. And this is like a really important thing for like EMS to ask when they're responding to like a chest pain. Because imagine, you have you're responding to a call. You have an elderly, gentleman who is perhaps engaging in some vigorous physical activity in the evening, right? And that's why he has chest pain developing. And so you go up and, hey, have you taken any of these erectile dysfunction medications? And they can tell you, yes, I take sildenafil or something. You do not want to give nitrates at that point. There are other things you can do to help out with the chest pain, but that's not going to be the one because the profound hypotension is going to be really severe, and that can actually make things worse for the patient. So really important thing, you do not want to mix those two classes of drugs together. We'll talk more about these in urology in terms of how they work for erectile dysfunction. Wouldn't it be obvious in that case? Not necessarily. What if the patient didn't want to tell you what they were doing beforehand, So you don't want to take anything for granted and assume anything because that can get you into some trouble there for sure, right? Anyway, so as I mentioned, could lead to hypotension, MI, stroke, lots of bad things. All right, so this is a good slide. It kind of gives you an idea of like what your first line drug should be for patients with anginal symptoms, what your backup are, and what you should be avoiding. And most of this should be pretty clear cut based off of what we talked about already. So for instance, if they have hypertension, well, a beta blocker is totally fine, right? Because that'll help out with the blood pressure. It's also going to help reduce myocardial oxygen demand. You can see here, beta blockers are recommended for most of the time, right? Good for low LV function, like for CHF patients or prior MI, they need to be on those anyway. So it makes sense for beta blockers to be useful in most cases. If they have bradycardia or AV block, well, obviously you don't want to do anything that's going to make that worse, so that would lead your non-DHPs and beta blockers to be contraindicated. So if I give you a test question, I say something like, oh, a patient has diabetes and they're requiring something for anginal symptoms, you would say, okay, well, I know that using something like non-cardioselective beta blockers is going to be bad for their diabetes. That might be contraindicated to some degree. Doesn't mean you can't use them, but just maybe that could lead to worsen glucose control and things like that. So kind of have a feel for this, kind of know why we use an alternative here, know what the backup agent is if we couldn't use one versus another, and that can kind of guide you and lead you to answer some of these questions correctly. So we'll look at some examples of that in the Kahoot a little bit later on. Okay. Now, those are the main drugs used to either treat acute symptoms, in the case of nitroglycerins, short-acting nitrates, and then things that help to prevent symptoms, in the case of beta blockers and calcium channel blockers and long-acting nitrates. Now I want to get into the ACE inhibitors and other drugs that kind of help not necessarily treat the symptoms of angina or prevent them, but they help with mortality long-term, right? And so this is where ACE inhibitors can be really helpful here. Good for patients with coronary artery disease, with diabetes, with LV dysfunction, all really helpful here. Because even though it doesn't really do anything for oxygen demand specifically, and they don't relieve symptoms, they really help prevent that cardiovascular arterial disease progression, right? So they can help out with that LV function, keeping that strong as long as possible. You see mortality benefits out of it. So this is why we do this. This is really handy, and it should be used indefinitely in patients who are post-MI, LV dysfunction, or diabetes, right? Why do we like it for diabetes? because it's kidney protective, right? It's going to help to stave off the kidney disease that a lot of those diabetic patients develop, okay? And again, when you're looking at combo therapy, typically you want to go ahead and initiate this if a patient is not responding well just to monotherapy by itself. So if they're on a beta blocker and they're still having symptoms with activity, then you can go ahead and consider adding on something else. Again, I would usually, as an add-on, I would consider something like a dihydropyridine in those cases there, or a long-acting nitrate. Remember, don't do a beta blocker plus a non-DHP. That's going to be too much AV nodal blockage going on there, okay? And if a third agent is needed, the patient's probably already seen a cardiologist, so again, they probably need further workup, maybe need some PCI or something like that to try to open up those vessels there, okay? In terms of antiplatelet drugs, you're going to want to use here, aspirin is going to be sort of the go-to unless someone has like a contraindication to it, right? So we know it's helpful to prevent acute coronary syndromes from happening here. It's going to be really indicated for all patients with ischemic heart disease. Note that we don't use it to necessarily prevent primary myocardial infarctions anymore. We really have found that now that the data is out, this only really prevents recurrence. So someone who's already having atherosclerotic disease, that's when they really need the aspirin. Like someone who's never had a, let me see. Yeah, it's being recorded on my end. Sorry, the chat's not as obvious on my screen, but anyway. So it's not going to be good. You know, you can just have like a 45-year-old start taking aspirin who's never had a history of cardiac disease and expect any mortality benefits. But if they've had a previous history of MI or something, then yeah, they're definitely going to benefit from that aspirin there. If you couldn't use aspirin, then something like an ADP receptor antagonist is a good backup there. Just as effective. And again, you'll have a little bit higher bleeding risk, but it's also going to be more expensive and all of that. And of course, aspirin, you can just find baby aspirin anywhere, and it's relatively cheap. So use aspirin first line and something like clopidogrel or another ADP receptor blocker as backup. All right. So in general, unless they have contraindications, you want to use aspirin. Especially if they had a previous history of MI or any kind of cardiovascular disease. Beta blockers for prior MI. ACE inhibitors with diabetes or LV dysfunction. A lipid-lowering therapy, which is most likely going to be moderate or high-intensity statin therapy like we talked about before. And then they'll have an as-needed prescription for sublingual nitroglycerin for acute relief, okay? Remember, acute relief is with the short-acting nitrates. Beta blockers are not used for acute relief of anginal symptoms, for prevention, right? So as I mentioned, prophylactic therapy, beta blockers, calcium channel blockers, and long-acting nitrates. So have a feel for where these come into, because I guarantee you I ask a question every single year. I'm saying, what is good, what drug would be best suited for this patient for prevention of anginal symptoms? And someone will pick short-acting nitrates. It's like, no, that only treats the acute symptoms. It doesn't do anything long-term. That stuff only lasts for a couple minutes, right? So again, keep in mind where these drugs are going to be working at. All right, now if they have variant angina or that vasospastic angina, like I mentioned before, typically a DHP is going to be sort of the go-to in that case there. So typically like amlodipine or something can be fine. Nitrates can also be useful as a backup, but for most patients, you know, dihydropyridine is going to be fine. Typically avoid beta blockers for those patients there. It actually ends up worsening their symptoms. So just a note on that. Okay. So now let's change gears. Let's say we were trying to manage our patient's anginal symptoms as best we could, but we just couldn't do it well enough, and now they've developed acute coronary syndrome. What are we going to do for them? Obviously, you've probably gone over some of this with Dr. O already, but we know the different delineations here of like non-ST elevation versus ST elevation MI. I'm not going to get super in-depth in terms of you know, diagnosing this and all kinds of stuff like that. Yeah, so aspirin first line for anginal symptoms. Again, aspirin's not going to treat those symptoms. It's for prevention of future acute coronary syndromes, right? For mortality benefits. That's when you're going to be using that. You're going to see for the most part, therapy here is going to be fairly similar in terms of medications. So we're going to look at what we're going to do. And a lot of it depends, like, you know, where's the patient at? Do they have access to a cath lab? How quickly can they get to that cath lab? You know, do they need bypass? Do they need a stent place? Some of that is going to change sort of the flavor of drugs that you're using. But for the early stages, it's all going to be roughly the same medications here, right? And again, what are we looking at? And it kind of makes sense on the medications we're using based on the pathophysiology. So let's say we have our little plaque here in a coronary vessel that's just kind of hanging out. You know, has a nice fibrous cap, so it's pretty stable there, but still occluding some flow, right? But let's say something happens, either procedural injury, like a balloon is being deployed here, or we have a spontaneous rupture. That is then going to, you know, expose all of that collagen and that von Willebrand's factor and all that stuff that's going to start to lead to platelet aggregation, right? The platelets are going to kind of join on there. They're going to start to expose those 2B3A receptors. They're going to start to bind together with fibrinogen and all that good stuff. And then we're going to have that fibrin clot, and that's what actually causes the majority of the occlusion there. at the site. And then we have our chest pain, we have our ischemia happening here. That's where we're going to intervene. So you can already expect to see where certain medications can be very useful here. Things like aspirin, things like anticoagulants are going to be very handy in helping to prevent this from propagating itself and getting any worse, right? And of course, this is the final occlusive thrombus here, just a very tiny amount of blood flow or no blood flow as the case may be, right? So looking at this, you can see the different spots where some of our medications can come into play here. And again, it's not just intrinsic or extrinsic pathway. Generally, both are kind of happening concurrently. And so you got to focus on both the platelet side of things and on the clotting cascade side of things. So typically, that's why you'll end up seeing for patients like this, they may be on combinations of anti-platelet therapy like an ADP receptor antagonist and an anticoagulant like heparin, for instance, at the same time, because they're going to be targeting kind of both facets of this occlusion that's happening here, right? And again, they typically feed into one another. Thrombin can help to activate further platelets, and that can cause a positive feedback loop to be occurring there. And again, you can see sort of this initiation with factor 10 playing a role here, factor 2. Remember we said 10 and 2 typically are most important in terms of the common pathway and how those can both feed back and further ramp up the intrinsic and extrinsic pathways there. So you can already see where heparin is going to be coming into play pretty strongly here, right? Or low molecular weight heparins or whatever we're going to be using. So, and then the whole cascade gets amplified because thrombin factor 2A is going to come in here and just further activate more platelets. Again, don't get too lost on the details here. The main ones I've already talked about before in terms of focusing on, like factor 7 initiating the extrinsic pathway, 2 and 10 being part of that common pathway. Those are kind of the really important ones I kind of want you to focus in on, and which factors our drugs are inhibiting, right? Because this is a pharm class, you got to know that. So, and again, that propagation here also leads for more thrombin to be formed, and that leads the conversion from fibrinogen to fibrin, right? And remember, there's also the step after this. So once you're done with that clot, you can have fibrinolysis that can occur, and that's also going to be another spot for our drugs to come and play a role here, okay? So what are we doing for our patients? Obviously, we want to reestablish coronary blood flow, relieve that chest pain because it can be very, very painful for the patients there. And if they're not at an MI already, try to prevent progression. Remember, time is tissue when you're dealing with these type of patients here. And then, if we can, try to save as much tissue and try to prevent things like development of heart failure. And obviously, if you can, prevent death. Typically, we like to keep our patients alive. That way they can come back and see us again and give us another copay, right? Just kidding. But I can keep them alive regardless. So what do we do? So common pharmacologic therapy. This applies to both STEMI and non-STEMI acute coronary syndromes here. First off, aspirin. They need to get aspirin on board. Even if they're taking 81 milligrams of aspirin a day, make sure they get a dose of about 325. Typically, we'll have them take them. You can do 4 81 milligrams. You get the same dose roughly. And you're going to go ahead and have them chew that up and then swallow it. It's really handy that they chew it up because it helps to aid the dispersion of the drug and they absorb it more quickly, right? And that's been shown to reduce mortality and reinfarction in those cases there. So that's absolutely critical. They need to get that on board. And remember too, like patients may not have that available. So like EMS might be the first ones to give it. But it's really important that someone asks the question like, hey, did you take aspirin already? How much did you take? I had one patient one time, I probably shared this story before, but he used a lot of like goodies powders anytime that he had chest pain. Someone told him, hey, just take one of these whenever you have chest pain. And he was having recurrent chest pain throughout the day and didn't realize that goodies powders was powdered aspirin. So when EMS showed up, they said, have you taken any aspirin today? And he goes, nope. And so they go ahead and they give him a full dose. And then he gets into the ER, and I guess EMS didn't tell him what they were giving him. Sometimes, in a fast-paced environment, the patient may not have even heard it. And then the resident says, have you had any aspirin today? And the guy says, nope. And so he goes ahead and gives him another dose. And all of a sudden, the guy's complaining of ringing ear, and he's having kind of breathing fast. And now he's got aspirin toxicity on top of the STEMI he was having, right? So again, these things can happen where you have medical errors on top of the condition the patient was there for in the first place. Anyway, so nitrates, right? Nitrates, no improvement in outcomes. This is simply for symptomatic relief, right? And this is, again, why a lot of times back in the day, we would tell patients, we'll take nitrates every 5 minutes, and then if you don't get relief by the third one, call 911. But again, this doesn't do anything for them in terms of outcomes, and if anything, it delays definitive therapy. So this is why we say if the first dose doesn't do it after 5 minutes, go ahead and call 911, come and get picked up, so that way you can get evaluated to see what else is going on here, right? But really important there, just for relief, does not do anything in terms of outcomes, right? And then beta blockers actually is really important to get online as early as possible as well, because we do see a reduction in MI. Now again, if they come in their bradycardic, they have severe AV block due to the MI in the first place, you skip the beta blocker until they're more stable. But if you can, if they come in and they're tachycardic because their heart's ischemic and they're trying to keep the cardiac output up, that could be a case where beta blocker can be useful in those cases. It'll drop down the oxygen demand by the heart and can help save some of that tissue there. Okay, so very important to get that on board if it's reasonable and it makes sense. So in terms of aspirin, obviously any contraindications, they have an allergy, recent GI or intracranial bleed, you want to be cautious here because again, they're probably going to be getting other anticoagulants potentially, and so you want to know that history to see if they're at risk for any further bleeds. And again, very handy for its benefits in terms of recurrent ischemia, infarction, stroke, all that stuff, right? As I mentioned, with the nitrates, you want to start with sublingual therapy, which the patients will be typically doing at home. And then once they're in the hospital setting or the pre-hospital setting, you can consider doing IV infusions, right? So especially if they're still like really hypertensive, it could be useful for one to treat the chest pain, and the IV infusion can get the blood pressure under control too. So that's one option as well. Be careful though. I've seen some patients, I've seen actually one case where whenever you're saying like the units that you want a drug to be given at, be really careful there because sometimes the pumps that the nurses will program in will have multiple options available, which is actually a really bad practice, and I hope this hospital doesn't do that anymore. But the provider said, okay, we'll start nitroglycerin at 20. And so the nurse then had to interpret, what did that 20 mean? Does that mean 20 mics per kilo per minute? Does that mean mics per minute? What did it actually mean? He meant 20 mics per minute, but then the nurse had programmed it as mics per kilo per minute. So that means now you took that 20 multiplied by the patient's weight, which was say 100 kilograms. Now they're getting 100-fold the dose that they should have. And the whole bottle of nitroglycerin basically infused into the patient. All of a sudden he's complaining of headache. He's hypotensive, right? So medical errors are super more common than you might think. It's kind of scary, to be honest. But be careful with the units you're infusing things at. And again, what do we worry about? Hypotension, headache, reflex tachycardia. This is not great if they're having ischemia because, again, that can increase oxygen demand. And so something like a beta blocker can help out with that in those cases there. And obviously, I mentioned if they're already hypotensive, then skip it. You don't want to worsen that. If they're on a PDE inhibitor like sildenafil, skip it as well. Again, it's only providing symptomatic relief. It doesn't do anything for their mortality. So it's, I guess, say pain's weakness leaving the body. That's not necessarily the case here, but they can handle that pain for a little bit if it's going to lead to them having really severe hypotension, right? It's not worth it. Okay, so then as mentioned, beta blockers, typically when they're in the hospital setting, we'll start IV and then we can switch them over to PO. So you can use like labetalol or metoprolol, something like that. Again, specific agents, I'd rather you just know the beta blockers instead of which ones I specifically mentioned here. But obviously they're bradycardic, hypotensive, they have heart block, or if they're like severe reactive airway disease, go ahead and skip it at that point, right? So you want to know the contraindications, which would make these options bad for your particular patient you're seeing on a question or in person. But these are good because they do reduce mortality for these patients here, reduce infarct size, heart failure incidence, all of that. So again, these are necessary unless they have a contraindication. Let's see. So we're starting to say that's when you skip the beta blocker. Again, if they meet these conditions, or bradycardic, hypotensive, I'd probably go ahead and skip it there. So beta blocker is normally contraindicated in an MI except for if it's the only thing left you can use. No, I would say beta blockers you want to get on board early. Because you want them to go ahead and get that extra benefit of decreasing the oxygen demand. It would only be you'd skip it if they have one of these conditions here. So if they come in and their heart rate's already like 45 because the heart's so infarct, and then yeah, you would not want to give that, just worsen it. Yeah, so couldn't we use a selective beta blocker if they have reactive airway disease? That's a great thought. That's absolutely what you could do. In those cases there, you could consider using cardioselective beta blocker. Remember A through M. So just for your knowledge, like a good go-to cardioselective beta blocker to use IVs like metoprolol. That would be like a really good one to go with in that sort of situation there. And again, it's a relative thing, right? How bad is their asthma? If it's just like a seasonal thing and it's, not the season for it, then it's probably not likely to be a big problem for them. Just depends on the situation. Okay, so then morphine, right? So everyone knows about morphine being used. Talk about Mona being used for your patients. We call Mona for chest pain, morphine, oxygen, nitroglycerin, and aspirin, right? Morphine is handy because it does help out with the pain, but it really doesn't necessarily do anything for your mortality benefits. So in these cases here, if someone could not receive nitroglycerin because maybe they'd taken sildenafil recently, then you could use morphine or any opioid analgesic as an alternative. There's nothing magical about morphine. You could use Dilaudid, you could use fentanyl, any of those are totally fine there. It's really just for management of chest pain, unresponsive to nitrates. So if they are fine with just the nitrates and their chest pain is manageable, then they don't need an opioid. No reason to give if you don't absolutely have to, okay? But it's usually pretty painful, so you still may require some additional pain management there, okay? keep in mind with morphine, and we're going to go over opioids much more in depth next semester when we talk about pain management. So I'll just really kind of mention this one here. But one of the things you'll see with morphine is it does cause a lot of itching because it actually causes histamine release. And so it's not uncommon for patients to actually develop hypotension as well as a result of all that histamine release. So if they complain of itching, or they say they have a morphine allergy and a lot of it's just itching, it's not necessarily rash necessarily, or flushing, you know, that could be the hypotension risk they're seeing with that. Sometimes you can administer an antihistamine to block that. But again, I would rather just skip the morphine altogether if I don't really need it. Okay, I don't want to add additional drugs to treat side effects of other drugs if I don't have to. Okay, so we're talking about our clotting cascade, right? So we remember talking about the intrinsic pathway, extrinsic pathway, talking about where things like fibrin are going to be coming into play here and all of that, and where our different medications may be able to inhibit this in order to manage these conditions. Now, again, would something like warfarin be effective in acute coronary syndrome? Well, probably not, right? It's going to take too long to kick in, right? It takes a couple of days for you to really have full effects because it's not doing anything to active clotting factors circulating around. It's inhibiting new production of clotting factors. Like warfarin has no place in acute coronary syndromes, whereas something like heparin or unfractionated heparins can be very useful here, right? So it's not uncommon patients will get like aspirin plus like an ADP receptor antagonist for like platelet antiplatelet effects, and then they'll get put on like on a heparin drip, for instance. Again, heparin drips are nice because you can titrate the dose very effectively there. The next thing I want to talk about, though, is actually getting rid of that fibrin. Like, what can we do to get rid of that fibrin if it's there? And so this is where our fibrinolytics come into play. And so fibrinolytics are going to be something used, probably not as common as you might think. So back before we had like more readily available cath labs, this was kind of the go-to. These are the clot busters that you could use. This is kind of like pouring Drano down your sink and trying to unclog a drain. Like this is what this does to these clots that are occurring in the coronary vessels. But they are very dangerous to use because of the fact that they cause a lot of bleeding, very high risk for things like life-threatening bleeding. And so we realized that actually quick access to a cath lab is much better from a patient safety standpoint and from a mortality standpoint than using these drugs here. So we still use them occasionally. You'll use these, for instance, if a patient's having an ischemic stroke. These are the drugs we're going to use for that. If you have someone who, say, for instance, has a line that's placed, like a PICC line, a peripherally inserted central line, and placed for a long time, and it gets clotted off in that line, we can actually use fibrinolytics to help break that up too. So I'll talk about some of the different uses here in a little bit. For acute coronary syndromes, though, it's unlikely you're going to be using it too frequently, but I want to make mention of the drugs here just because I don't really have a better place to put them to, right? Or put them at. Anyway, so what is this going to do? Well, basically, we have plasminogen floating around, usually inactive, and that's usually a good thing because if it doesn't need to break down fibrin, then we don't need it to be active. But it becomes converted to plasmin by a tissue plasminogen activator. So if you've ever heard of TPA, that's what that's referring to. If you hear the TPA as like a clot buster or for occluded lines or something, that's the drug they're using there. We have a synthetic variety we can use. And anyway, plasmin is helpful because it can help to lyse open and break down fibrin, fibrinogen, and factors 2, 5, and 7. So very effective if you already have an active clot going on somewhere. They're like a massive PE or a ischemic stroke, I should say, or an occluded coronary vessel. These can be good to try to break that down, but the downsides are going to be numerous, as we'll see here. There's a couple different ways for this to occur. There's a picture I have here in a second that kind of shows you how that works. But basically, the main one I'll talk about here is going to be TPA itself and how it binds to plasminogen, actually bound to fibrin. So this is actually handy. It doesn't work on just plasminogen kind of all over the body. It's actually only working on the stuff that's bound to fibrin where it's kind of most needed. So that can be useful to help kind of preventing excessive bleeding elsewhere other than where the clot actually is. So you can kind of see how this works here. The different things like streptokinase can come in here, plasminogen. Once they bind together, that can then help to convert plasminogen over into plasmin, and TPA and things like urokinase are also useful here. So it's just different ways they get the same process done. Don't be too worried about the actual steps here. Just know that they're ultimately what we're doing is converting plasminogen over into plasmin. That's the main goal here. So Brian Singh, we had a patient who came in complaining of stroke symptoms, and they ended up giving him TPA, but apparently had surgery on one of his great vessels a few weeks before. It broke down the clots, and he bled out. That's a great segue into, I'm sorry for your patient, but it's a great segue into some of the contraindications we'll see here in just a little bit. Yeah, it's really, really important to know your contraindications. Anyway, so we can see we have a couple different agents here. So we have things like tissue plasminogen activator, TPA. we'll have things like Retiplase and then Tenecteplase. Those are probably the more common ones you're going to run into that are available here in the US. And they're all pretty similar in terms of adverse effects that you're going to see. And what is the main one? It's going to be bleeding, right? I'm going to put this in red and highlight it and underline it and italicize it because that's really important. Bleeding is going to be the main side effect you're going to see here. And in fact, major life-threatening bleeding is the biggest risk, right? And we say, bleeding risk with like aspirin. I mean, like minor bleeding maybe. Heparin a little bit higher. This is like the most risk for bleeding because, again, it's actively breaking down clots, right? Especially anywhere they might be, they'll break them down. The other big thing you can see here too is going to be allergic reactions. So you can see things like fevers and chills and whatnot. Anaphylactic reactions can also happen too because these are sort of like human-made proteins that we're having to engineer and applying to the patient. So they can detect that foreign protein sometimes and have an allergic reaction. That's a risk for sure. There is some risk for ventricular arrhythmias as well, but also too, if your patient's having acute coronary syndrome, they're at risk for ventricular arrhythmias anyway. So it's hard to say whether it's, the TPA they got or if it's the MI they were experiencing at the same time, So this is an important list here. I'm going to go ahead and bold all of these because you want to be able to know what your contraindications are in terms of giving something like TPA, right? So some of these are going to be pretty obvious. So for instance, like surgery within the past 10 days, organ biopsy, head trauma, cardiopulmonary resuscitation. This is kind of like what your patient there had happen that led to them bleeding out, right? Because again, those vessels were not completely repaired, and so they ended up being broken down, the clots, and they bled out, right? Any gastrointestinal bleeding within the past 3 months. So this could be like, a peptic ulcer that bled or something like that. If they have a history of hypertension, and note here, this diastolic pressure greater than 110, not systolic, but diastolic. There are cases where you can try to give antihypertensives to get the patient's blood pressure under control. So it's not uncommon. You might give like a IV beta blocker or something, try to get that down. And if you can, then it may still be a candidate. But just by itself, a diastolic greater than 110 is going to be a contraindication. Any active bleeding or hemorrhagic disorder, that makes pretty good sense. Previous cerebrovascular accident or active intracranial processes like tumors and things like that. Aortic dissection, acute pericarditis, any previous allergic reaction or prior exposure to like streptokinase, which this one I wouldn't really worry too much about because we didn't really talk about streptokinase too much. And then pregnancy, obviously, because that would be very bad for the fetus to bleed out. So again, some of these are pretty obvious, right? So if I said someone had come with a diastolic blood pressure of 115 and, they just had, ischemic stroke 2 weeks ago, that's going to be a problem, right? Or hemorrhagic stroke 2 weeks ago. Does it matter what systolic is? No, I think they're more worried about the diastolic because that's like kind of your baseline pressure. And so that's where they more draw the lines there. If your diastolic is like 110 or higher, your systolic is probably going to be very elevated regardless. So as I mentioned, we have Alteplase, we have Retiplase, and then Tenecteplase. Alteplase is going to be recombinant TPA, basically. So if you ever hear TPA, this is what they're talking about, is the Alteplase. Could you use in a patient who had a CVA many years ago? That would be very dependent. I would definitely want to confer with the cardiologist, right? If it was a cardiology thing, or if it was a stroke, then I would want to talk to the neurologist. That's why they have stroke teams. That's why they have, cardiac arrest teams and stuff there, because they can go through these checklists and they can make determinations, that sort of thing. Because it needs to be a team effort when doing that to make sure there's nothing they would want to do it. Like how remote was it? It's hard to say. I would say though that if they have any previous cerebrovascular accident, they are at bigger risk. So I would be definitely cautious there. And again, most of the time for patients for coronary stuff, they're going to be going to the cath lab because that's usually available in a lot of places. If you're working out in the middle of the panhandle, if nothing available, it could be another story altogether. All these drugs are going to be really expensive because they're all having to be recombinantly made. So for instance, like TPA or Alteplase, this is the one we use most frequently in the hospital. This is also what we use for a lot of like our occluded catheters and things like that. We'll use that in intracatheter. And so you can see here it's made with DNA technology using Chinese hamster ovary cells. Again, I don't know what's so special about those Chinese hamster ovary cells, but they do a pretty good job of making Alteplase apparently. But regardless, all going to carry the same risk, all are going to have the same side effects associated with them. So you can kind of think about these all very similar to one another. I'm not going to ask you if it, was it Indonesian hamster ovary cells or was it a guinea pig from France? I'm not going to ask you stuff like that. But point being is that that these are recombinant drugs, so anaphylaxis risk is elevated, bleeding risk is going to be there, all of that, right? And know what your contraindications are. And again, sometimes the determination on when to give it is frequently based off of like symptom onset too. So for instance, like, the older you are, obviously your bleeding risk is going to be elevated. And then the longer the symptoms have been occurring, the less likely the drug is to be effective. So for instance, if they're less than 75 and they're within 12 hours, then you may be a candidate. If they're too far beyond that, then the risk of the drug outweigh the potential benefits of breaking down that clot there. So that's the thing you want to be worried about. And again, relatively few patients are getting them now, but you still may be ordering it pretty frequently, right? So I see PAs all the time order it for patients who have catheters in place and they have occluded lines, and they'll order TPA intracatheter to actually have to break that down, so that way you don't actually have to go and get a whole new line placed, because that could be pretty difficult from a technical standpoint. Depending on the patient there. You can see here bleeding risk anywhere between 0.5 and 7%, intracranial hemorrhage up to 0.5 to 1%. So you don't want 1 in 100 patients likely to get intracranial hemorrhage, so the risks are quite high with these drugs here. All right, some other agents you're going to see occasionally include things like the 2B3A inhibitors. These you may not see routinely done before PCI necessarily, but you may see them situationally being used there. Someone like Professor Gerke could probably tell you more about his experiences since he's dealt with a lot of these patients. I've only seen them in the ER basically, where we get them kind of stabilized and then move them out to the cath lab, so I don't have a ton of follow-up on all of these patients here. ADP receptor antagonists, typically these are going to be used prior to PCI, and then usually as clot prophylaxis afterwards with stent placement. And so I'll show you a picture of that in a second here. So, imagine you have a stent placed here in this vessel, and you can either have like a drug-eluting stent or like a bare metal stent. Any kind of like foreign hardware, like catheters or stents like this or anything like that, platelets and things like that like to bind to it. And so that's why you can see risk for clotting off happening here, and that's why we end up giving antiplatelet therapy. Typically, we do dual antiplatelet therapy, so we'll do things like aspirin plus clopidogrel, for instance, and the two of those together, they'll be on it for a period of time, maybe 3 months, 6 months, a year, longer, indefinitely. Just depends on the situation there. So that's where we can get away with using those. And then typically, heparins are going to be used in conjunction with things like fibrinolysis and antiplatelet agents to prevent any further clotting from occurring as a result of that clotting cascade. Marley's saying during the hurricanes a few years ago, when the hospital I worked at couldn't fly people to the big hospital for the cath lab, we had to give TPA for STEMIs, and everyone was terrified to do it. It's real scary. I ain't gonna lie. Like, when you give it, you're just like, please don't bleed out and die. Please don't bleed out and die. And some of those patients were destined to die anyway, so you can't save everyone, but it is certainly, you don't want to be the person who ordered that drug that led to that. So that's why it's usually a team effort. Everyone's got to concur together and say, okay, yeah, this is the right drug for this patient right now. So that's a scary thing to have to do, but live in Florida, we got hurricanes, so it is what it is. So as I mentioned with non-STEMIs, these are all going to be pretty similar in terms of early treatment. So again, oxygen, aspirin, nitroglycerin if it's appropriate, all of that. Typically for non-STEMIs, we're not going to use fibrinolytics because, again, those vessels aren't completely occluded there, and the bleeding risk is just too high for the potential benefits you get with that. And then they usually use low molecular heparins over heparin. For whatever reason, they find better evidence with that, so you might see that occasionally. And then you'll see 2B3 inhibitors used a little bit more commonly. So, all right. So I think the last thing I want to talk about here is going to be chronic heart failure, which is going to be, some of this is going to be relatively good review for a lot of the other drugs we've already talked about. I don't think there's a whole lot of new medications here necessarily. But again, why do we get CHF? Well, frequently it's as a result of ischemic heart disease, like MI previously. But things like hypertension, dilated cardiomyopathies, things like that. Even certain medications can actually lead to CHF. So for instance, things like there's certain cancer drugs. There's a drug called daunorubicin and doxorubicin. There's a lifetime amount that you're only able to get for the entire patient's life. If you go too much above that, then your risk for things like CHF developing are too high. So we'll talk about that later on. But yeah, even drugs can do this. Cobalt's a metal that can actually lead to cardiomyopathies and things like that. So a lot of things can lead to CHF. So in terms of systolic dysfunction, this is going to be more related to decreased contractility. A lot of this is related to things like left ventricular hypertrophy, but you can also see things like dilated cardiomyopathies as well. And typically we're assessing these as having a reduced ejection fraction. So we're going to see with some medications we can use to try to help out with this, to try to allow for the heart to beat more efficiently and to try to prevent symptoms for these patients from developing. So that way they can still get around and do the things they want to do, right? With diastolic dysfunction, this is typically more of a result of impaired relaxation. So having left ventricular hypertrophy also makes the walls thicker and stiffer, so they can't really relax all that efficiently before the next contraction. And so that can lead to some impaired filling and things like that. And of course, even with areas of ischemia, that actually can cause some impairment in terms of calcium recycling. And so that can lead to impaired relaxation there as well. So that can be a bit of an issue for those patients. And so overall, decreased filling, thus decrease cardiac output in those cases, right? And so in some cases, you may see they'll have a preserved ejection fraction, and that's more related to this diastolic dysfunction. Most of this is part you've already covered with Professor O. The thing I'm trying to illustrate here are some of these compensatory mechanisms that come into play and how our medications can sort of try to disrupt this a little bit to allow for either delayed progression of symptoms or treatment of active symptoms and things like that. So basically, what is the body going to do to respond to this decrease in cardiac function? Well, a lot of it can be related to increased preload. So your kidneys are going to detect low pressure, low salt, things like that, and it's going to say, okay, let's hold on to more of that. Let's increase ADH function. Let's increase aldosterone function. And so you're going to hold on to more sodium and water, right? And what do a lot of patients with CHF have? They have a lot of edema in the periphery, which is going to lead to volume overload, right? So we're going to see there's some things we can do to help treat that. You'll see vasoconstriction, so hypertension is very common with this, which just worsens their afterload, right? Sympathetic nervous system activation leading to trying to kind of ramp up the heart's activity to try to keep things up, which can further lead to damage over time. And that just worsens overall hypertrophy, right? The more you use a muscle, the thicker and less compliant it's going to be getting. And you can see how a lot of this stuff tends to kind of worsen in on itself. It's kind of a sick cycle with a lot of this. So we want to use our medications to try to disrupt some of this, including things like the renin-angiotensin system or a lot of the salt and water reabsorption and all of that to help out with things like the congestion and edema, the dyspnea that they develop there, the weakness and fatigue. This is our main goal, is to try to help arrest some of these things to try to allow for some resumption of normal function for these patients. All right. So, and two, you have to think about these patients, they can either be sort of like a maintenance mode or they can decompensate. And so we want to think about reasons why they decompensate. Unfortunately, a lot of times it's medication non-compliance. A lot of these patients get kind of tired of taking meds all the time. They feel worse while they're taking the medications, so they stop taking them. So that can be one issue. They're not being compliant with their salt restrictions and things like that. Uncontrolled hypertension, arrhythmias, all these things can happen here that can lead to decompensation, where they basically, the heart just cannot keep up anymore, and so they typically have to be hospitalized for this, and that can lead to some issues in and of itself. But of course, infection as well can always lead to some issues additionally. So in terms of non-pharmacologic therapy for CHF, obviously limiting dietary intake of salt and fluid is going to be very helpful here. But again, this is where a lot of non-compliance comes from, because as it turns out, a typical US diet is full of salt. And we do see, though, if you can do this, it helps to limit physical activity and can definitely help improve some of their functional status for sure, right? Now, in terms of what are we going to do for these patients here, what do we want to do about those fluids? Like, how can we get rid of those fluids off of the patients? They have a lot of pitting edema, maybe that's some pulmonary congestion. What can we do to get rid of that? Well, thiazide diuretics typically are not going to be potent enough for most heart failure patients. They can still be used more for routine blood pressure management, but they're not going to be as efficient as we would like to get rid of that fluid. So that's where our loop diuretics are going to come into play. And you'll find some patients will be on loops as a continuous drug. They'll just take it, 2 or 3 times a day, every day. Some of them might be on a PRN dose of loop diuretic. So that way they can check their weight every day. And if it starts to go up by a certain amount, they'll know that most of that's probably fluid. And they can start taking their water pills, as they call them. And that can help to get rid of some of that extra fluid. And recall how those are working. Working that loop of Henle, that's the most effective place for a diuretic to work, to prevent salt reabsorption. And then all that water falls right out as urine. Okay. And again, what's this going to do for us? It doesn't necessarily do anything in terms of mortality benefits, but it does help to decrease preload and does provide some symptomatic relief, right? So get rid of some of that extra fluid, their weight's going to go down, have a lot of that congestion sort of clear up. Very helpful in terms from a symptomatic standpoint. One thing I will note here with the CHF drugs, I want you to know what's going to help us to provide mortality benefits and what's just for symptomatic relief, right? So not every patient has to be on a diuretic if they don't have fluid overload, right? Some drugs, every patient needs to be on because it does provide mortality benefits. I'll show you what that looks like in a few minutes. And again, monitoring their weight is the best way to detect that fluid overload. So if more than 1 pound a day for several days, chances are that's all fluid. So as I mentioned, diuretics only for symptomatic relief. No evidence of disease progression slowing or mortality benefits there. And so not mandatory, but very helpful for a lot of them. Now, ACE inhibitors are going to be sort of our golden key for patients with LV dysfunction with CHF because it kind of does a little bit of everything. It helps to decrease preload, helps decrease afterload, will decrease sympathetic activation, helps by preventing remodeling. So if you have that LV hypertrophy and dilation, it slows that down. Now, again, it doesn't reverse anything, unfortunately, but it does slow it down, which is very handy. And so we can help to prevent symptom progression, and it decreases mortality. So unless they have a really big contraindication to it, almost all these patients need to be on an ACE inhibitor or an ARB as an alternative if they cannot tolerate an ACE, right? So what are the benefits other than hemodynamic improvements, a better exercise tolerance, fewer hospital admissions, slowed progression of disease, and better survival? Great on all fronts there. So again, very effective therapy, a lot of bang for your buck with ACE inhibitors. Okay. What are the problems though, right? So recall that we can see some issues there. So for one, if we find that they have concomitant, renal dysfunction, remember acute initiation of ACE inhibitors can really drop the renal function if they require angiotensin II to clamp down on the efferent arteriole. So if you have someone like that, start low and go slow. Again, this is not a race, it's a marathon for these CHF patients typically, unless they're like in an acute decompensation. Obviously, you want to watch the blood pressure, but typically most of these patients are hypertensive regardless. Watch their potassium. Remember, if they've had a previous MI and they have all these ischemic areas of the heart now, then you may see that they're more at risk for arrhythmia, right? And so changes in potassium can exacerbate that. So you do want to watch potassium levels because that obviously be elevated with an ACE inhibitor, right? Remember, what would a diuretic do to the potassium levels for the most part? Like a loop, make it go down, right? So you want to keep in check what drugs are affecting potassium levels because that's a very easy way to kill someone if you get their potassium out of whack too far, right? And then cough we talked about in the angioedema. Remember, cough being more specific to the ACE inhibitors themselves. Beta blockers are also really important here additionally. So they used to be thought of as completely contraindicated because of, just like we would see with non-DHPs, you don't want to decrease the contractility, you don't want to decrease heart rate necessarily. And so they used to thought you just not do it, right? Because they can actually induce decompensation if you're not careful. But we do now know that there's going to be mortality benefits. And so these are the three main ones you'll see used: carvedilol, metoprolol succinate, which is the XL formulation. Remember the hard candy analogy I used with that for the succinate versus the tartrate, which is immediate release, and then bisoprolol. So make sure these are the three, for specifically this indication, right? Could other beta blockers do it too? Maybe, but we don't have the evidence to show that. So that's what we use. The key here is that you got to be really careful when initiating this. The patients need to be stable to begin with. And so, for instance, this is where in hospitals typically where they're going to initiate that. So it'll probably be in-house, starting off on one of these very low doses and titrate up. And sometimes they need like 6 to 8 weeks to get up to a kind of a full effect dose there, because again, depending on that degree of LV dysfunction, you got to be really kind of careful with these patients here. And obviously monitor for signs of heart failure, decompensation, look for increases in weight gain, look for decreases in activity, things like that, right? So the benefits, you're going to get improved exercise tolerance because, again, you're helping the heart to be more efficient when it's beating, right? And so that can help out them with their activities of daily living. They get around better. Will help out with the hemodynamic improvements, right? Especially if they have, with the increases in ejection fraction you can get there because the heart has kind of more time to fill, you can beat more efficiently. And then it will definitely slow down disease progression. So less hospitalizations, less transplant needs, and decreased mortality. So CHF, got to be on an ACE inhibitor. Most likely got to be on a beta blocker. And again, so far loops are going to be for symptomatic management. So first line therapy for class 2 to 4 heart failure. Again, know if a patient, for instance here, if you're looking at this, if they had a history of asthma, right, are any of these going to be inappropriate for them? Probably carvedilol, right? Carvedilol is not necessarily going to be specific to beta 1 because it's that 3rd gen. But metoprolol and bisoprolol would be perfectly reasonable here if they had that history of reactive airway disease. So be cautious and make sure you're reading the vignettes on the test question to see which ones are most appropriate for that particular patient. Okay, so as mentioned, patients should be on ACE and a beta blocker irrespective of symptoms. Let's talk about a new drug. Here's one called Digoxin. This is actually kind of a steroid-looking drug. If you know what steroids look like, kind of shares a similar molecule here. And actually, this actually comes from some plant sources. If you ever are driving along highways in Florida and you see on the medians, if you ever see these colorful plants, sometimes they're pink, sometimes they're yellow. They're called oleander. Those actually are a source for digoxin-like compounds. That's why they're actually really dangerous, like animals and kids to get into, because they can actually cause dysrhythmia. But digoxin itself can be useful as a medication both for arrhythmia management and also for management of CHF. So what does digoxin do? Sometimes you see called digitalis, same name for the or different names for the same thing essentially. So what digoxin is going to do is basically, imagine here you have a cardiac cell, and we want to inhibit this ATPase pump. Remember, what does the sodium potassium ATPase pump normally do for us? Well, it shuttles potassium into the cell and sodium out of the cell against their concentration gradients, and it establishes and maintains resting membrane potential. Okay. So if we inhibit this, what's going to happen? Well, we're going to have a bunch of extra sodium sitting here within the cell, and that's actually going to stimulate this antiporter here to be more efficient. So we're going to have more sodium leaving out through here, but then that sucks in calcium. Well, what is calcium really helpful for? Well, calcium is going to be in higher concentrations, so you're going to get more of it being released from the sarcoplasmic reticulum, and thus you're going to get a stronger squeeze. So you can end up seeing that by giving digoxin and inhibiting the sodium potassium pump, you end up getting better contractility out of the heart. That's one way we can use it for CHF potentially. So that's its use as an inotropic agent, right? Inotrope meaning it's going to helping out with the actual contractility of the heart there. This is kind of the old mechanism for why we thought this works so well. Nowadays, we realize there's something called the neurohormonal effects. It's sort of a new way we think about it as being used for CHF, and it actually helps to decrease sympathetic tone and increases parasympathetic tone on the heart, and also can help to resensitize those baroreceptors we talked about. Remember how they get set to a new set point when you have like chronic hypertension. So that can help out with that, and it decreases renin-angiotensin aldosterone system effects. So overall, these are kind of the big benefits now that we use digoxin occasionally, and not every CHF patient will get this, as we'll see, but it can be useful from those purposes there. So again, this is what they're doing. We're seeing that by blocking sodium potassium pump, this can help to reset that baroreceptor reflex, which can also help to reduce heart rate. Increasing parasympathetic effect on the heart can slow down conduction, right? Which can be somewhat useful there to help with better filling times and more efficiency. Less sympathetic activity means lower blood pressure, and overall you're going to get better cardiac output, so better pumping actions, right? So you get more efficiency out of that heart. And then overall, reducing renin-angiotensin effects is also going to be good too for a number of reasons, including the vasoconstriction and all of that. So overall, you're going to see here that it is handy. It doesn't necessarily, it's not a slam dunk in terms of any kind of like mortality benefits. It's more so for symptomatic management. So if you have a patient who's on an ACE inhibitor, they're on a beta blocker, but still symptomatic, maybe digoxin can be an okay to add on to it. So not everyone. And the reason why that is there's a lot of downsides to it. It's actually a very narrow therapeutic index drug. If you look here at the doses, the levels you're shooting for, and don't memorize the level, I'm just putting it here for your reference, it's 0.5 to 1 nanograms per ml. I mean, most things we saw are like micrograms per ml. This is nanograms, so extremely small amounts here are needed to get their effects. Getting higher than that can actually be associated with worsened outcomes. Because again, you get too much decrease in contractility and things like that, that can be a problem. So what do we end up seeing here? So overall can help out with symptoms, improves exercise tolerance and all of that, and can decrease hospitalizations, but no survival benefit. So this is not like a mandatory drug these patients have to be on by any stretch of the imagination. Okay. So as I mentioned, does not slow down disease progression, but can be useful if patients are kind of optimized on everything else and they're still symptomatic. You can add this on potentially. However, if they do have AFib, and we'll talk about its use as an antiarrhythmic later on, but for patients with AFib, these are useful to help out with rate control. For those patients there. So I'll talk more about that in the next section for the next test, so you don't have to worry about that too much here. But can be considered for symptomatic heart failure with systolic dysfunction. That's kind of like the main place you'll see it being used. So why am I hesitant to use it in a lot of patients? Because it is fairly toxic. It can really, if you get the levels wrong, and again, this is another renally eliminated drug, so if you have someone like poor kidney function, as someone like CHF might have, you can find here they can really get into some trouble. And actually, you know, when I hear about like different overdoses coming into the ER, there's certain things where I'm just like, I don't really care about that. It's not going to be too dangerous. There's certain things where I get like very worried about it. So I always talk about like the sphincter tone level. So how much you clench up when you hear about it. Like aspirin can be like a 9 on the scale of 1 to 10. You know, digoxin can be like a 8.5, something like that. It's pretty scary if you see some of these ingestions come in. So what can happen, and most of the time it's like elderly patients who like their renal function's gone down, no one's gone back and readdressed their dose, is where they usually get into trouble. So I note these side effects here because they're actually pretty unique, and if you hear about this, this could be a really good one that you can see like on board style questions, or if someone's trying to pimp you, things like that. It can be very handy. I don't know if Van Gogh was on digoxin or not. He might have been. Maybe that's where they said the Starry Guys come from. Starry Night. Isabel's saying in the last PowerPoint says beta blockers decrease exercise tolerance, and this one says it improves exercise tolerance. Very good. Yes, for typical like otherwise healthy adult patients with just like hypertension, beta blockers can reduce exercise tolerance, right? Because they decrease the amount of increase in cardiac output you can get by the sympathetic nervous system if I needed to go run or something. However, someone with CHF who has this sort of impaired filling, and you can see that you know their efficiency is down. By giving a beta blocker and titrating it effectively, very slowly, you can actually lead to more efficiency in terms of how the heart's pumping, and that actually improves their exercise tolerance. So it seems kind of counterintuitive, but it actually benefits them. And again, that's a relatively recent discovery. We thought for a long time beta blockers are just contraindicated for them. Anyway, so they can also reset the baroreceptor reflex. Yeah, so beta blockers can do that additionally, so that can also be useful there. Okay, so the digoxin toxicity you want to kind of know about is certainly a lot of GI effects. You can see nausea, vomiting associated with this, but more interestingly are some of the visual effects you can actually get from this. And so you can get things like blurred vision. You can get like halos around lights, and they have something called xanthopsia. So xanthopsia, xanth mean like yellow. So you can see yellowing of the vision. So it's kind of yellow-green halos around lights. And so that's maybe where the Van Gogh association kind of comes from there. But if you ever hear about that, that should really clue you in. This is like the only drug that does that. So that's very, you know, pathognomonic almost for digoxin toxicity if you hear about that. I actually remember one time when I was in pharmacy school, I was like in my first year of school. And it's actually interesting in that first year, like I actually didn't learn anything about drugs. It's like a whole year just like pathophys and all kinds of other stuff that I didn't find to be all that too helpful because I wanted to be there and learn about drugs. But I remember I was like at a YMCA in town, and I remember that, you know, I don't know if anyone's been to a YMCA before, but there's a healthy elderly population that likes to hang out there, especially in the men's locker room all day long apparently. But regardless, you can actually find that I heard a guy actually talking about it. He's like, yeah, I'm on this new heart medication, and kind of weird because I keep seeing those weird halos around lights. I remember him saying that like, specifically. I was like, boy, that sounds weird, but I didn't know any better, so I just kind of kept doing my thing. And later on, I was like, wow, that guy actually had digoxin toxicity. I probably should have said something to him, but like if I knew what I was going to say to him, I'd be like, hey, go see a doctor, I guess. But I didn't know any better. So hopefully the guy's still alive. He actually was probably like 12 years ago, so it might not be. Who knows? But anyway, what are some other things we can see here too? So we can see some central nervous system effects. This is typically with like pretty elevated levels here, so you wouldn't see this with like normal dosing, but again, part of that narrow therapeutic index you can see with these. So abnormal dreams and dizziness and whatnot. The other really important thing though is the cardiac effect, right? No one's going to die from having yellow vision, but it's the arrhythmias that can be really problematic. And there's really almost any type of arrhythmia can occur with digoxin, which is why it's really kind of interesting there. But bradycardia is probably the most common, and oftentimes you're going to see these like PVCs that will pop up here that are pretty specific with digoxin. So I'll talk about this later when I talk about antiarrhythmic specifically, but really any antiarrhythmic drug can cause arrhythmias. Is kind of the oxymoronic thing about them. Same thing with seizure medications and whatnot. But point being is you do want to be careful here. So if anytime you have someone who you're worried about having digoxin toxicity, you got to get an EKG like right away on them, right? And some contraindications to watch out with would be advanced AV block, severe bradycardia. This can worsen that. If they're already having PVCs or any kind of ventricular tachycardia, this can be exacerbated by that. And then things like hyperkalemia, hypomagnesemia, or hypercalcemia. Okay, the hyperkalemia is actually really, really important because you can actually find that digoxin increases potassium levels in the blood. And you're like, well, why would it do that? Well, if you look back at the mechanism here, what does it do? Well, it stops this pump from working. So all that extra potassium that would be shuttling into the myocytes are now stuck on the outside. So that can actually lead to elevated levels. And if you have someone who has CHF who is on an ACE inhibitor and they're maybe taking potassium supplements because they take Lasix and then they're on digoxin, that can lead to having hyperkalemia, and that can lead to arrhythmia. So you got to be really cautious and look for those changes in their electrolytes, right? And again, a lot of times you won't see that most Chem 7s are not going to include things like magnesium, calcium. So you may have to get an extended panel there, like a CMP or something, to make sure you capture that. So definitely want to check out that. And then it can exacerbate Wolff, Parkinson, and White. So you do want to avoid it in those patients there. So what do you do if you have too much digoxin on board? The patient comes in, they're complaining those yellow lights, and you're seeing all these PVCs on the EKG, and you're really worried about them developing an arrhythmia. What do you do? Well, we actually have an antidote for that. Of course, anytime I mention an antidote, you probably want to know about it because, again, I'm the tox guy, so I like to know about this stuff too. So there's what's called a digoxin immune fab. So this is actually a pretty neat thing. So basically what they do is they can take ovine proteins. Does anyone know where ovine comes from by any chance? You can put it in the chat there. But basically, they'll hyperimmunize an animal against digoxin, essentially, and then they can separate out their antibodies for that digoxin, and then we can then give that to people to bind up and neutralize the digoxin. We're using animal proteins essentially to try to bind up the digoxin that keeps it from working on the heart. So it's actually really effective. It actually works like almost immediately as soon as you give it. Those antibodies just bind it all up, and then the patient can just eliminate it. It does not come from Chinese hamster ovaries, but yeah, it comes from sheep. So it actually comes from hyperimmunized sheep. You can isolate that out. And it's kind of neat because if you were to imagine like a typical antibody, if I were to draw one out, if you imagine it kind of looks like this, it's probably not good. Kind of this is a poor approximation of a antibody, but basically this whole antibody, if you just give a full sheep protein, anaphylaxis risk actually goes up pretty high. But what they do is they take some proteins, they're able to actually cleave that, and we just give this portion here, and that's what actually can bind to the digoxin itself and neutralize it. So it's actually pretty neat because the overall risk for anaphylaxis is pretty low. So good for reversing that toxicity and allows for the sodium potassium pump to start to work again, essentially. Okay, so next up we have a few aldosterone antagonists. These are also going to be helpful. Spironolactone is going to be good for mortality reduction in grade 3 or 4 heart failure. So if they're a little bit more progressive, 3 or 4 heart failure, this is where you want to go ahead and give them spironolactone. Keep in mind though, one of the big things here is that if you recall, spironolactone inhibits aldosterone. What's that going to do in the kidneys? Well, it's going to lead to more sodium excretion, but you're holding on to more potassium, right? So this is why potassium is going to be contraindication for these patients here. Or if they have too high of a serum creatinine, avoid giving spironolactone or pleuronone, okay? Because it's going to aggravate that even more. But if the patient's on Lasix every day and hydrochlorothiazide for their blood pressure, and they're on an ACE inhibitor and they're on this, maybe it balances out, right? So that's why you got to monitor for every patient. It'll be a little different depending on the case there. And remember, the partial testosterone effects you're going to have at those receptors. So gynecomastia is pretty common. So you can switch over to something like a pleuronone is perfectly reasonable there. You get the same benefits out of that. Again, the reason why we like it for CHF is because it actually causes some neurohormonal inhibition and it actually slows down some remodeling of the left ventricle. So it kind of slows down progression. So that can be helpful from that standpoint, but just specifically for these grade 3 and 4 heart failure patients. Okay. Now let's say if we have patients who are coming in and they were, say, an acute decompensation, and we wanted to do something to get their cardiac output up right now, what could we do? And so we have a couple agents for that. These are called inotropic agents or positive inotropes. These can be really helpful here. So we have two that work on specifically phosphodiesterase 3. It's going to be milrinone and an amrinone. Now we talked about phosphodiesterase before in relation to things like nitroglycerin and how that broke down cyclic GMP. There's a few different flavors of phosphodiesterase. There's 3 and 5 are the main ones you're going to run into. 5 is really important for working on like the lungs. It can actually help out with reducing constriction of the vessels in the lungs. It can also treat erectile dysfunction. That's PD5. PD3 is much better for working on the vasculature, right? Affecting blood pressure here. So this is why they're a little different. You wouldn't use these drugs to treat erectile dysfunction because it doesn't affect the right phosphodiesterase, okay? But anyway, what these are going to do is they prevent phosphodiesterase from breaking down cyclic AMP. This can actually help to do a couple of things. One, it can increase cyclic AMP concentrations in the heart, which increases contractility, and it can also reduce blood pressure. So it kind of helps with getting the LV function up and reduces afterload, which is good if these patients are hypertensive at the same time, right? So direct stimulation of the heart, balanced arterial and venous dilation happening there. So it helps decrease afterload and overall improves cardiac output. These are IV medications you're giving though. So again, this is like if you're having a decompensation, they come into the hospital, right? So typically we're using this for just short-term use. We actually find increase in morbidity and mortality long-term because it can induce things like arrhythmias and whatnot. So you do want to be careful there and some risk for thrombocytopenia. So again, helpful in the short term to get the heart kind of kicking again. And then once the patient stabilizes, then you would remove that. A few other ones we have include dobutamine and then dopamine. I'll talk more about dopamine probably next semester when I get into more of the vasopressors, but I'm just more focusing on the positive inotropes right now. Dobutamine is going to be a selective beta-1 agonist, right? So it's going to be helping out the sympathetic nervous system by activating beta-1 receptors to increase squeeze on the heart, to increase contractility. It will have some effects on heart rate as well, and it's going to help to get cardiac output up. Okay, so you could use, for instance, if I had a patient who was coming in with a decompensation and they were, low cardiac output, but their blood pressure was up, something like milrinone would be good for that. If their blood pressure was down and I didn't want to reduce blood pressure any further, then dobutamine might be a good option there. Or actually, dopamine would be an even better option because it has some benefits of affecting both beta receptors in the heart, and then if you get a high enough dose, it can actually cause some alpha constriction of the vessels as well. So it really depends on the patient in terms of what their cardiovascular status is, and that will lead you to choose one versus the other potentially. And that's it for that section. So I'm surprised I actually got through it all in the time that I had. That's fantastic. So what about the patients who are on long-term milrinone drips? What's your definition of long-term? So when I'm talking about long-term, I'm talking about like weeks to months. Typically, you won't see that because, again, that risk for some of the side effects is going to be a little higher. You might see it for like a couple of days, though, for a really bad decompensation, I think. So just depends. Very cool. Let's see if there's any questions on the board. Okay, let's see here. Still got the surprise there. I answered that one already. Okay, so to clarify, in regards to treatment of angina, when using ACE or antiplatelet agent, should we be using that in combo with other agents, correct? Since they don't release symptoms or affect O2 demand, such as a nitrate or something of that sort. Yes, so those will be drugs that the patients will be on regardless because of the improved mortality benefits, preventing them from progressing into stuff like CHF, from having an MI, so they got to be on those regardless. And then if they're having anginal symptoms with activity, say if it's like super like not common for them to have it and it's only under like strenuous activity, maybe they only have like a nitrate on board. But if they are going to be more frequent than that, maybe a beta blocker is going to be a really good first step to go with, and that's going to help to prevent those symptoms from happening there. But you'd have the ACE inhibitors in the background regardless, in the aspirin as well. Do we need to know which grades of heart failure drugs correspond with, or just knowing which go with heart failure? Okay, the only one you need to know is the aldosterone antagonist, right? You just need to know those because that was specific for grades 3 and 4. All the other ones you could use them for any of them, totally fine, right? I think I talked about that. See, in the first-line treatment for angina's beta blockers, why would you avoid it in variant angina? It can have an effect because it doesn't do anything to the vessels, right? So it can have basically if you slow down the heart, but the issue is the vessels are spasming. It doesn't treat the actual condition, and so by using a dihydropyridine, it relaxes those vessels, so it prevents a spasm from developing, I guess. So that's kind of the best way I kind of think about it. And then does digoxin immune fab kind of act like Narcan in a way? Yeah, kind of like that. Maybe not quite as quick. Narcan, for those of you that don't know, is the reversal agent for opioids. So if I had someone who got too much morphine, for instance, you can give Narcan and it wakes them up like right away. It basically kicks all the morphine off the receptors and blocks that. This does a similar thing, but instead of binding to the sodium potassium pump, it basically will bind to the digoxin and then render it inert. Basically, you can't interact with the receptors any further. All right. Any other questions? Let's see, can you again explain why you would choose dopamine over dobutamine in certain instances? Yeah, I would say, and again, if you talk to someone who does cardiology like all the time, they probably have a more a reasoned answer, perhaps. Typically, if you have someone who is like hypotensive, and they're coming in there, the low cardiac output, and they're coming to decompensation, dopamine's a good one there because you can bump up the dose and actually get some good vasopressor effects, and that will raise the blood pressure back up. If blood pressure was not an issue and you just need to get that cardiac output up, then something like dobutamine would be a good option there. So really just depends on the situation. Again, if you talk to Professor Gerke, for instance, he's always my go-to for cardiology stuff. He could probably give you a much more like elucidated answer of like, oh yeah, for this particular type of patient we do this, and for this type of patient we do this. I can more speak in broad strokes. We use dopamine pretty frequently over at Nemours, but we use it more so for the vasopressor effect. So if you had someone like come in for sepsis or something and they had hypotension, that's kind of what we'd end up using it for there. So, all right. What other questions do you guys have? Nothing currently. Okay, so if you would like, you are free to go. Unless you have any questions or something, I will continue to be on here doing our Kahoot because I wanted to give you some people the benefit of being here live if they chose to be. I know everyone's so excited to get out and start their Friday studying of Pharm, so it's like it's just going to be Pharm from here until Monday at 9:30. So that's probably okay. But we can go ahead and get started here. Again, this is all optional, so I don't want anyone to put on my evals, he made us stay till 5 o'clock for a review. I did not make you do that. You chose to do that. Trying to add value for all the money you're paying to go to school. I want you to make sure you're getting your money's worth. So guys, can you see the number? All right, good. People are coming in. C's do get degrees, technically. You know what you call the guy who finishes or who graduates at the bottom of his med school class? Call him doctor. Oh, I hate Pharm. That's sad. Kick you out for that. There you go. It's better. 76 is the goal. I think most of you and all of you can do better than a 76. I have total faith in y'all. There were a few more miss. No one is debat like I am, so. You could be, though. I don't know any PAs that have gotten their board certification in toxicology, but you could potentially. So you got about 40 in. So if you want to join in, the pen will still be there. I'm going to go and get started just for the interest of time here. So we do have several questions. If you have anything to post up on the sticky board, feel free, or you can just interrupt me, and that's totally fine too. All right, which of the following is able to affect blood pressure and heart rate from the level of the CNS? Be verapamil, minoxidil, felodipine, or clonidine? How dare I force education upon you? Ugh. I think where the drugs are specifically working at in the body. Very good. Right. So remember, like, specifically like a calcium channel blocker, like that's working on the heart. It's working on the vessels. Remember your DHPs like felodipine are going to be working more primarily on the vessels. Then verapamil is going to be working primarily more so on the heart, right? Minoxidil, remember that was a direct vasodilator, so of course that was working on the vessels there. But clonidine working centrally, right? It's helping to shut down the sympathetic nervous system a little bit, or at least turn it down. And that's why you end up getting the sedation associated with it. That's why you end up seeing its benefits for like pain management sometimes. That's why you end up seeing the blood pressure and heart effects are coming from the CNS down, essentially. So it's good to know kind of where these drugs are working at. Very good. What's up, Prism Mike? We talked about the Dementors. Which of the following medications can help preserve renal function in diabetics? Quinapril, furosemide, atenolol, or candesartan? All right, so and again, I don't like to put two right answers on my test questions, but I can do that here. Remember, either of these would be fine. So if you had someone who could not tolerate an ACE inhibitor, an ARB is totally fine to use as backup. That's perfectly reasonable there. You have furosemide, not going to do anything to preserve renal function, even though it does increase urine outflow. It doesn't help prevent progression of renal disease, right? And then atenolol being a beta blocker also does not really help out from that standpoint either. Okay. All right, up next, a patient with chronic constipation should avoid which medication? Diltiazem, bumetanide, prazosin, or minoxidil? Let's say someone's on oxycodone chronically, they had chronic constipation. What do we think? Very good. Yeah, so diltiazem is going to be the most likely one to exacerbate this, because remember, calcium is needed for all smooth muscle to constrict, right? So this can affect it kind of everywhere. And so you may see this a little bit higher propensity with the DHPs, but yeah, that can slow down calcium influx into the GI tract smooth muscle, which slows down peristalsis. That could definitely worsen that. Bumetanide, not so much. You know, if anything, trying to think, I wouldn't expect to see a whole lot of constipation, not nearly as much as you would see with the calcium channel blockers, right? And of course, sometimes we may see what's, you know, is it possible it could do it? Maybe, but it's much more likely with the calcium channel blocker. And then not really so many issues with prazosin or minoxidil, at least to my knowledge. Right. So patient develops rhabdomyolysis after taking simvastatin and what other medication? If they were taken with verapamil, lisinopril, alirocumab, or ezetimibe. Interesting. Okay, so got to think about, goes back to our conversation about CYP inhibition and all that from the very beginning here, right? So even though you could maybe increase some risk of things like, you know, hepatic injury and things like that with the combination of something like ezetimibe and simvastatin, that's, I mean, those drugs come as a combination, right? So it can't be that bad if they, you know, combine it together in the first place. But the more thing I want to focus on is like when you have these metabolism interactions, it can really raise levels of these drugs pretty significantly. And in the case here, verapamil being a 3A4 inhibitor can certainly do that, right? So simvastatin's affected by that. Atorvastatin's affected by that, and I think of those two as kind of more common statins. But the other one that avoids that problem is rosuvastatin. If you recall, rosuvastatin was on that high intensity list. That you can get some, so it's like atorvastatin and rosuvastatin. You get kind of the most intensity out of those. You know, I could have put atorvastatin, and that would have been the same answer here. But Crestor or rosuvastatin would have avoided that completely. So think about which drugs are kind of most appropriate, especially if you have to add on new things, like if you had to add on verapamil for whatever reason, how that would affect the other drugs the patient's on. Maybe it would require dropping the dose of simvastatin so the risk is not as high. Maybe it would require you to use a totally different drug altogether. Okay. All right. Okay, which of the following drugs can cause CYP3A4 induction? Actually, I think I took this part off here. I don't have a pulmonology question on here. It's very interesting. You guys should know this anyway, though. Good. Almost a slip by my review. This won't be on the test, though, so don't worry about that. Yeah, it's actually rifampin is that one there, but that should have been on your test for Palm, so you guys should definitely know that one. But which one does the red-green discoloration or just color discrimination? Even remember? No one, no one. Is that the Ambutal, if you recall that? And then isoniazid is actually related to. Very good. Isoniazid is actually related to some interesting toxic effects that can happen from its blockage of production of GABA, so it can actually induce pretty bad seizures, which is why you have to give it with pyridoxine. And actually is related. There's some mushrooms that actually have the same kind of toxicity as that, which is kind of neat. Anyway. All right, which of the following could cause cyanide toxicity in patients with liver dysfunction? Nitroprusside, phenoldiprem, tamsulosin, or nicardipine? Every time I hear someone leave, I'm like, did they just get fed up with me and they just said forget it and I'll watch it later? Hard to say. I do not blame any of you for having a nap time for sure. All right, so if you recall, nitroprusside was that one that has basically the nitric oxide molecules surrounded with like 5 cyanide molecules. That's one we end up having to give with sodium thiosulfate to try to prevent the cyanide toxicity there. So again, that's a unique sort of side effect. That's a good thing to know when you're getting into like rotations or something. It's a good pimping questions, or good board style questions. Just good to know in general, like why you want to be cautious with certain drugs, because you can develop this sort of toxicity here. Yeah, I took a nap while watching Pharm lecture this morning. I am a very good cure for insomnia. So if you just turn me on as you're going to sleep, I guarantee you probably won't wake up for the test in the morning for sure. So I really hope I can laugh about my score right now come Sunday night. Well, we shall see. There's going to be so much learning over the weekend. I'm going to get so many emails of people asking me questions. I'm looking forward to it. Be waiting by my computer, waiting for it to happen. Which anticoagulant works with antithrombin 3 to inactivate factors 2, 10, 9, 11, and 12? Fondaparinux, enoxaparin, heparin, or warfarin? All right, yes, heparin is the correct answer here. So remember, heparin's more working on the intrinsic pathways. So that's where you get like the 9, 11, and 12 effects there. The 2 and 10, though, obviously being part of that common pathway. If I'd said warfarin, could have been here 2, 7, 9, and 10, because those are the main ones that it's affecting in the liver in terms of production of those clotting factors, whereas heparin obviously is going to activate, or going to be working against the already activated forms that are floating around. Now, why would not enoxaparin or fondaparinux be correct here? Because again, they lack a lot of this additional activity. So if you recall, with going with low molecular weight heparins like enoxaparin, it's mainly affecting 2 and 10, but really it's predominantly affecting 10 with a little bit of 2 activity. On the other hand, fondaparinux, even shorter, is actually just going to be affecting factor 10 by itself. And recall how that affects the monitoring parameters too. With something like unfractionated heparin, APTT is generally going to be used most commonly, whereas both fondaparinux and enoxaparin, anti-10A is going to be more recommended because that's predominantly the clotting factor that it affects, right? Versus warfarin, which we know is going to be PT-INR, obviously. So what medication can mitigate the unique side effect of immediate release niacin? The hydralazine, acetaminophen, torsemide, or aspirin? And part of the process here should be able to look at the drug, identify what class it falls into, and you should pretty immediately be able to rule in or out some of these options here, right? So say, okay, what kind of drug is torsemide? Do I need to include this in my list of possible answers or no? Or can I get rid of it, right? Yeah, so the last question I had, unfractionated heparin inactivating those clotting factors, is that correct? That is true. Unfractionated, yeah. So remember, unfractionated heparin is the same thing as just heparin, right? That's just the original normal heparin that we produce ourselves. When I say low molecular weight, that's when you start to chop it up and you get like enoxaparin, okay? So heparin and unfractionated heparin, if I say that, that's synonymous with one another, okay? I use heparin when making nuclear medicine ultratag RBC kits. Cool to know how it works. Interesting. I have not heard of that before. Yeah, remember aspirin helps out with the flushing effects you can see there with immediate release niacin because of the prostaglandin synthesis that occurs as a result of taking niacin. Acetaminophen would not work here because it really doesn't affect cyclooxygenase in the same way that something like aspirin or an NSAID might. So aspirin is definitely the go-to recommended one there. All right. So which medication would be recommended in a patient with an isolated hypertriglyceridemia? They had a familial hypertriglyceridemia or something like that. Cholestyramine, fenofibrate, ezetimibe, or atorvastatin. LDL is fine, HDL is fine, it's just the triglycerides are high. Very good. Yes, the fibrate would be correct here. I also could have put niacin here, and that would have been reasonable as well, because both of those kind of have similar effects on dropping triglycerides and bumping up your HDL, if you recall. Obviously, which one would be contraindicated for a patient like this? That would be your cholestyramine, like your bile acid sequestrants can actually raise your VLDLs and your triglycerides there. So you got to be cautious with that one. Now, if you gave the patient atorvastatin Would their triglycerides go down? Yeah, for sure, but it wouldn't necessarily be as specific as using something like a fibrate. So that would be the best option in this sort of case here. All right. Which of the following diuretics would exacerbate hyperkalemia? So make it worse. Would it be acetazolamide, spironolactone, metolazone, or furosemide? All right, so you definitely want to know which drugs are going to lower potassium or raise potassium because, again, very easy to harm someone that way. And especially if you're mixing and matching different medications, you got to know what is going to do what, right? So in these cases here, acetazolamide, it's a carbonic anhydrase inhibitor. If anything, it's going to cause hypokalemia. So it actually drop the potassium levels. But again, remember where it's working in that proximal convoluted tubule, so it's going to have the most modest effects out of the bunch because you still have the rest of the nephron that can affect the salt and the water balance there. So you still have the loop of Henle and the DCT and collecting duct and all of that. Metolazone, remember that's a thiazide-like diuretic, so that's going to cause hypokalemia if anything, so I could actually lower it, which is good. And then furosemide would also help to get rid of that extra potassium as well. This is if you had someone that came in like that and they were volume overloaded and they had hyperkalemia, this would actually be the go-to. You'd probably want to use Lasix here to treat that. Spironolactone though could exacerbate. It's going to make the levels go up in that situation due to its aldosterone inhibiting effects there, right? So I have an idea for how these different diuretics are working and what different shifts are going to cause in electrolytes because that can again be a source for common medical errors that we cause is causing things like hyponatremia or hyperkalemia, things like that. All right. Next, which anti-lipemic would be best for a pregnant patient? Would you use rosuvastatin, cholestyramine, gemfibrozil, or ezetimibe? Talked about two big classes of drugs that are like super contraindicated in pregnant patients. Probably three. But yeah, just remember your statins are no good in pregnant patients. Do not give a statin to a pregnant patient. Just like you do not give warfarin to a pregnant patient, you do not give ACE inhibitors and ARBs to pregnant patients, right? Very teratogenic. On the other hand, though, when we're looking for ideal candidates of drugs to give to pregnant patients, we're trying to limit systemic exposure to the fetus, right? And so anything that doesn't get absorbed from the GI tract is generally the ticket to go with. So cholestyramine or a bile acid sequestrant would be the best option in this case here. Now, again, is that pregnant patient going to be very going to like you a whole lot? Probably not, because again, they're having a lot of GI effects anyway, just from the pregnancy. If you add on all this extra abdominal cramping and all these other problems that come with the bile acid sequestrants, that's going to be an issue. So again, trying to weigh the pluses and minuses. Can you do it with diet alone? Do you need to use a bile acid sequestrant? That's a risk versus benefit sort of thing you got to look at there, right? Okay. A patient has endocarditis. Oh, see, I should have taken this one off. I actually cut this out of the slides here. But let's say we have someone with endocarditis and they have MSSA. Which of the antibiotics would you want to give them? This one won't be on the test. I just forgot to cut this out of the slide or the Kahoot. But if they have MSSA, which antibiotic would be the best? Oh, someone said, what is metolazone? That is going to be a thiazide-like diuretic. Remember, that's the one that you can still use, even if the creatinine clearance is less than 30. The loops continue to work even with low creatinine clearances, but thiazides lose their efficacy once you get like below 30 mLs a minute. But except for metolazone, that one still works. Yeah, so everyone went Vanco, but remember, MSSA, you want to go narrow spectrum if you can. So if you can scale it back to something like dicloxacillin, that can be very useful. Remember, that's an anti-staphylococcal penicillin. So that's a good one to go with in that situation there. Again, this will not be on the test. This was an error on my part. I forgot to take it out. Because again, I did not have enough room in all my slides for it. All right, a potential side effect from the use of evolocumab is undetectable LDL, rhabdomyolysis, infection, or anaphylaxis. Yeah, there's actually two answers here. This is just kind of an interesting side effect that was noted in trials, which I thought was kind of neat. But we don't really know the clinical implications of that. The main thing to focus on, though, is the anaphylaxis risk, right? Because remember, it's a monoclonal antibody, so it's a foreign protein. So that risk is always going to be there to have some degree of allergic reaction, anaphylaxis to it, right? Rhabdomyolysis is not really reported with this one, so it's safe from that standpoint. Rhabdo is really going to be more seen with the statins, especially if you have any kind of interaction leading to really elevated levels of the statins, usually due to CYP3/4 inhibition or something. Which beta blocker would be best for a patient with poorly controlled asthma? Do we want to use metoprolol, pendolol, sotalol, or propranolol? Very good, yeah. So remember, the general caveat is if it's A through M, it's probably going to be a cardioselective beta blocker, so it'd be better for patients with asthma, reactive airway disease, COPD, etc. N through Z is typically going to be non-selective. So these three here are actually all non-selective. You just have to know which ones are the third gen that sort of defy that naming convention. So like labetalol and carvedilol, things like that. Very good. Which of the following meds would most likely cause acute kidney insufficiency when initiated? Be clonidine, which I spelled incorrectly, hydralazine, lisinopril, or prazosin. You can tell exactly how done each and every one of you are by your faces right now. So we'll be done soon enough, but stick with me. We'll get through this. All right, interesting. Nice little stepwise increase there. Right, so recall how these drugs are going to cause that kidney insufficiency when that happens. So I can draw out that nephron again, but remember, it was the raising the bars, yeah. So it was the angiotensin 2 that constricts that efferent arteriole, right? So that provides that back pressure on the glomerulus to increase filtration. If you introduce something like an ACE inhibitor for someone who's like in a high renin angiotensin state, um, like someone who has chronic kidney disease, you can let loose of that. It'll open up that vessel and cause a decrease in filtration pressure. That leads to less filtration and acute kidney injury, right? Or acute insufficiency. So you got to be really careful whenever you're introducing ACE inhibitors or ARBs in patients like that. Now, if it's a young, healthy patient, not a problem. They can handle starter doses, no issues. But if it's someone who has like a history of kidney disease, decreased kidney function, start low and go slow with those because again, you can cause an acute decrease in function. Just like doing an NSAID and introducing that would cause the opposite problem on the afferent arteriole, and by getting rid of those prostaglandins that are vasodilatory. So it can happen on either side of that. And so it's really important to know that because again, it's another common iatrogenic sort of medication error that we can cause harm to the patients by doing that if we're not careful. All right, which monitoring parameter slash drug combination is correct? APTT and enoxaparin, anti-factor 10A and dabigatran, PT-INR and warfarin, or thrombentine and fondaparinux? I hate when I already give away the answer. Why does lisinopril cough go away? I take it and only had to cough for around 4 months. I don't know why it went away for 4 months. Maybe it had some sort of change in regulation to where the bradykinin levels were not so high, perhaps. For some people, it sticks around as long as they're on the drug, so hard to say. All right. Yeah, so PT-INR and warfarin, definitely the correct one here. Remember, APTT is not reliably going to change in response to enoxaparin, right? Because it doesn't affect all those other intrinsic factors. So APTT is just going to be for heparin. Enoxaparin is fine with anti-factor 10A. Dabigatran, we don't really have any direct way to monitor for that, which is, again, good from a standpoint that I can give it to a patient and don't require monitoring. And then thrombentine is not typically used for any sort of drug monitoring of anticoagulation there. But PT-INR and warfarin, those two go hand in hand. All right, Dwight Schrute still in the lead. Sudden withdrawal of which medication could lead to severe rebound hypertension? Be amlodipine, chlorothiazide, irbesartan, or nadolol. There were kind of two classes of drugs we talked about that could do this. Very good. Yeah, so it's going to be your beta blockers and then your clonidine guanfacine, like the centrally acting sympatholytics. So remember, when you have a beta blocker on board for chronic period of time, you are blocking those beta receptors, and so you end up having a upregulation of all those beta receptors on the heart. So when you take that away, that drug away, all of a sudden it becomes much more sensitive. It's much more able to interact with like norepinephrine, and so you can rebound hypertension, tachycardia. This has induced MI in some patients, so it's really no joke to have a patient, if they run out of their meds, they gotta make sure they have some kind of access to it. So either get like a 3-day supply from the pharmacy or call you to get a script, whatever the case may be. You don't want them to go without. And similarly, if you needed to discontinue the med, then you want to titrate off slowly to avoid getting any kind of rebound effects. Same thing can happen with clonidine and guanfacine. All right. Which antidote/drug combination is correct? Say phytonadione or vitamin K with enoxaparin, idarucizumab and aspirin, protamine sulfate and heparin, or fresh frozen plasma and aspirin. What do we think? Very good. Yeah, so good to know your antidotal combinations. Not only is it helpful if you have a patient who's actively like having either a medication error or an overdose or something like that, to know quickly what to give, because time may be of the essence, but it's also good to know for board style questions and on rounds and on rotations and things like that. So remember vitamin K, what's that going to be for? Be for warfarin, right? Because it will help to start to produce new clotting factors. But if warfarin is not going to be, or vitamin K is not going to be a quick fix, right? Because it's going to take time for that to produce those new clotting factors. So what do you do in the meantime? If someone's having a major bleed with warfarin, get the fresh frozen plasma, right? That already has clotting factors in it, and so that can help to replace what the patient's missing. So that's the fastest way to reverse warfarins with that. Mentioned protamine sulfate and heparin go together, and then idarucizumab is actually good for dabigatran. That's the only those new oral anticoagulants or the direct oral anticoagulants that had an antidotal agent, the idarucizumab in that. All right, last question here. Which of the following medications could worsen LV function in a patient with CHF? Ramipril, verapamil, amlodipine, or propranolol? So worsen LV function in a patient with CHF. Very good. So two right answers here, right? So amlodipine, no direct effect on contractility, so that wouldn't necessarily affect LV function specifically. Similarly, ramipril would not have a direct effect there. Verapamil, though, certainly will slow down LV conduction, slow down contractility. That would definitely decrease LV function. And then beta blockers, remember, they can do that certainly acutely, even though propranolol is not one we'd use for a CHF patient, but acutely, yeah, it can definitely do that. If you start a full dose, that can be an issue for those patients. So I got to really titrate over the course of weeks to months in some cases there. So either of those would be reasonably good choices. So anyway, let's see who the winners are. We have 76 as the goal. Pretty good if your goal is 76 and you're third place. I think things are looking up for you. Huggies, which I have plenty in my house. And then right here, one of them that needs some in the background. And then Dwight Schrute. Who is that? Who's Dwight? Ah, very good, Isabel. So, since not everyone's here, I'm not going to give you a free answer. So I guess you'll never know that it was B the whole time, but whatever. It's okay. Thank you all. Oh my goodness, that's pretty good. Nice job. So thank you all for staying with me. Let me see what questions we have over here. The worst thing about Pharm was the Dementors and the tests. Yeah, that is very true. The tests were the worst. Some of you probably prefer Dementors over taking my test, I imagine. Any other questions or anything else? I'll be on here for a few minutes, but you guys are otherwise free to go. Thank you for joining me. I'll post up the video and the Kahoot link in just a little bit. So that way, if people aren't here, they can join in and review it, and you guys can retake it if you like over the weekend. I will be available via email, so if you have questions, shoot me an email. Again, 5 minutes of my time will save you hours potentially, so I don't mind. But if you email me at 12 o'clock on Sunday night, chances are low that I will get back to you. Yeah, you guys be safe as well.
I have a question.
Yeah, what's up?
Um, so should I also worry, like for test purposes, like which medications I need to be cautious for with like patients with renal impairment or like like dysfunction or something?
Mm-hmm.
Not like as an absolute, but it's like for the sides where you mentioned, oh, be careful of, like you would just want to watch out for it. Not like we absolutely can't give these patients these drugs, but like, oh well, if they have like impaired renal function, just like kind of watch out for that.
It depends. There's few drugs that you absolutely cannot give if patients have poor renal function, but remember there's certain ones we talked about. So for instance, like your thiazide diuretics, how they lose efficacy once you get below 30 mLs a minute. So that's not necessarily where it's like a toxicity from the drug, but it's the actual efficacy of the drug is not going to work very much if the creatinine clearance is too low, right? Except for metolazone, that was one exception to that rule there. The things that can induce kidney injury you want to know about, right? So we talked about ACE inhibitors, we talked about NSAIDs, not specifically NSAIDs on this test, but how that can have an effect as well. Um, when I mentioned things like enoxaparin being renally eliminated, that one you do have to watch for because, again, if you're giving full dose enoxaparin to someone with poor kidney function, I mean, you can cause them to start bleeding. So this is why I want to start talking about this stuff now, so that way you can start thinking about it and remember some bit of this when you go on rotations and be like, hey, this patient's on taking this much enoxaparin based on their kidney function, it should be this, and that's a big save you can make for some of these patients. So
Okay, thank you. Sorry, like
yeah,
I was
that was not
weird. I'm
maybe not
just
clear
like,
enough, but yeah.
thank you.
No problem. Is there any other questions or?
I do.
Yeah.
I'm still trying to figure out the best way for me personally to
Mm-hmm.
take on your classes we talked about.
Yeah.
And basically, what I just did was I went through and did notes myself on all of the PowerPoints, just reading them first. I mean, I watched the lectures, but then I think when I try to listen and type at the same time, I get way too behind.
Mm-hmm.
But I was wondering if you are still okay with me, like for a topic or something, coming up with what I think is important, and then checking with you.
Yeah, shoot me an email. Yeah.
Okay.
I'm gonna
I'll
check it
try
out.
to today.
Yeah, the sooner the better though, because again, if it's like Sunday night, it might be in bed
Yeah,
already. So.
right. Okay, I just wanted to make sure.
Yeah, for sure.
Hey, Dr. Wood, I have one question. It's
Sure.
actually not really related to this section, but
Mm-hmm.
regarding alpha 2 receptors,
Yeah.
I'm kind of confused as to why they decrease sympathetic tone.
Yeah. So it has to do with they call it autoreceptor activation. So or to draw it out for you. So imagine you have say your postsynaptic nerve here, and then you have your presynaptic nerve that's releasing. This is sympathetic nerve releasing norepi into the synapse here, right?
Mm-hmm.
Or handwriting. So there has to be an equilibrium between how much is being released out into the synapse and how much is like there's negative feedback loop to it, right? So that way it doesn't release all the norepi all at the same time. And so part of that has to do with these autoreceptors. So eventually when the concentration gets high enough of the norepi and stuff here, it'll eventually kind of just naturally kind of dissipate back here or disperse back here. And this is where your alpha 2 receptors are. This is one of the places where it works. And so this is alpha 2. And so when this gets activated by the norepi that is being released in the presynaptic neuron, it then shuts down further release of norepi. So by doing that and by activating that with a drug, you end up causing there to be less norepi being released from these sympathetic nerves in the first place. So that's how, from the level of the CNS down, it kind of is decreasing heart rate and blood pressure because it's activating these things. The nerve thinks, okay, well, there's enough norepi being released here, so let's go ahead and stop releasing anymore, and it shuts that down, or turns it down, I should say.
Okay, so are alpha 2 receptors only located in the presynaptic neurons?
There are some postsynaptic effects too you can potentially find. You'll see that in some of the slides, like when I mentioned like aproclonidine and bromonidine in the ophthalmology section. There are some postsynaptic effects too. The primary ones we're talking about for like a blood pressure issue is mainly this presynaptic effect here.
Okay, yeah, because I was asking because I was reviewing like the ophthalmology drugs, and I was a little bit confused about how I think it was the drugs for glaucoma, like how they can inhibit sympathetic tone. So. All right, well, that's all I really had. Thank you so
Cool.
much.
No problem. Have a great weekend.
All right, you too.
Bye.